Chapter 23, Cancer Development, M. Linda Workman. Learning Outcomes. For clinical competence and success on the NCLEX examination, study this chapter with these learning objectives in mind. Health promotion and maintenance. Assist all people to identify behaviors that reduce the risk for cancer development and cancer death. Teach the recommended screenings, practices, and schedules for specific cancer types. Physiological integrity. Explain why causes of specific cancers can be hard to establish. Use knowledge of basic biology to understand how normal cells can become malignant. Distinguish the features of normal cells from those of benign tumors and cancer cells. Discuss the roles of oncogenes and suppressor genes in cancer development. Compare the cancer development processes of initiation and promotion. Correctly interpret cancer grading, Ploidy and staging reports. Explain the common sites of distant metastasis for cancer and how metastasis contributes to death from cancer. Discuss the role of immunity in protection against cancer. Assess the individual patient's need for genetic testing for cancer predisposition based on family history. Altered cell growth, such as a mole or a skin tag, is common. Most types of altered cell growth are benign or harmless and do not require intervention. Malignant skin growth, or cancer, however, is serious and without intervention leads to death. Cancer is a common health problem in the United States and Canada. Nearly 1.5 million people are newly diagnosed with cancer each year. Some types of cancer can be prevented. Others have better cure rates if diagnosed early. As a nurse, you can have a vital impact in educating the public about cancer prevention and early detection methods. Although cancer is common today, it is not a new disorder. Some types of cancer are more common today, especially among more affluent societies than in centuries past. Two reasons for this increase are the long life expectancy of people in more affluent countries and increased exposure to substances that cause cancer. Cancer will occur in about 1 of every 3 persons currently living in North America. Jeez. Although cancer risk differs for each person. More than 10 million Americans with a history of cancer are alive today, nearly 5 million of whom are considered cured. Still aren't very good odds. Pathophysiology. Growth of cells and tissues is expected during infancy and childbirth, and many human body cells continue to grow by mitosis or cell division long after maturation is complete. Such cells are located in tissues in which constant damage or wear is likely, and continued bone marrow and linings of organs such as the lungs, stomach, intestines, bladder, and uterus, among others, have the ability to divide throughout a person's lifespan. The growth of these cells is well controlled, ensuring that only the right number of cells is always present in any tissue or organ. Some tissues and organs stop growing by cell division after development is complete. For example, heart muscle cells no longer divide after fetal life. The number of heart muscle cells is fixed at birth. The size of heart increases as the person grows because each cell gets larger, but the number of heart muscle cells does not increase. Growth that causes tissue to increase in size by enlarging each cell is hypertrophy. Growth that causes tissue to increase in size by increasing the number of cells is hyperplasia. Any new or continued cell growth not needed for normal development or replacement of dead and damaged tissues is called neoplasia. Any new or continued cell growth not needed for normal development or replacement of dead and damaged tissue is called neoplasia. This cell growth is also abnormal even if it causes no harm. Whether the new cells are benign or cancerous, neoplastic cells develop from normal cells or parent cells. Thus, cancer cells were once normal cells, but changed to no longer look, grow, or function normally. The strict processes controlling normal growth and function have been lost. To understand how cancer cells grow, it is helpful to first understand the regulation and function of normal cells. Biology of normal cells. Many different normal cells work together to make the whole person function at an optimal level. For optimal function, each cell must perform in a predictable manner. Features of normal cells. Limited cell division occurs because normal cells divide or undergo mitosis for only two reasons. One, to develop normal tissue, or two, to replace lost or damaged normal tissue. Even when they are capable of mitosis, normal cells divide only when body conditions and nutrition are just right. Apoptosis is programmed cell death. Normal cells have a finite lifespan. With each round of cell division, the telemetric DNA at the ends of the cell's chromosomes shortens. See Chapter 6. When this DNA is gone, the cell responds to signals for apoptosis. The purpose of apoptosis is to ensure that each organ has an adequate number of cells at their functional peak. Specific morphology is the feature in which each normal cell type has a distinct and recognizable appearance, size, and shape as shown in Figure 23.2. A small nuclear to cytoplasmic ratio means that the nucleus of a normal cell does not take up much space inside the cell, as shown in Figure 23.2. The size of the normal cell nucleus is small compared with the size of the rest of the cell, including the cytoplasm. Differentiated function, or functions, is a feature of normal cells. Every normal cell has at least one special function it performs to contribute to whole body function. For example, skin cells make keratin, liver cells make bile, cardiac muscle cells contract, nerve cells conduct impulses, and red blood cells make hemoglobin. Tight adherence occurs because normal cells make proteins that protrude from the membranes, allowing cells to bind. Figure 23.2, distinct morphology of some normal cells, shows some different cells. Okay, so tight adherence occurs because normal cells make proteins that protrude from the membranes, allowing cells to bind closely and tightly together. One such protein is fibronectin, which keeps most cells' tissues bound tightly to each other. Exceptions are blood cells. Red blood cells and white blood cells produce no fibronectin and do not usually adhere together. Non-migratory is the feature that means normal cells do not wander throughout the body, except for blood cells. This occurs in normal cells because they are tightly bound together, which prevents cell wandering from one tissue into the next. Orderly and well-regulated growth is a strong feature of normal cells. They do not divide unless body conditions are optimal for cell division. These conditions include the need for more cells, adequate space, and sufficient nutrients and other resources. Cell division, or mitosis, occurring in a well-recognized pattern is described by the cell cycle. Figure 23.3 shows the phases of cell cycle. Living cells not actively reproducing are in a reproductive resting state termed G0, or G with the coefficient 0. During the G0 period, cells actively carry out their functions but do not divide. Normal cells spend most of their lives in the G0 state, just like most humans spend most of their lives in a non-pregnant state. Mitotic cell division makes one cell divide into two cells. These two cells are identical to each other and to the original cell that started the mitosis. The steps of entering and completing the cell cycle are tightly controlled. Much of this control is regulated by proteins produced by suppressor genes. Control of whether a cell enters the cell cycle and completes the cycle to form two new cells depends on the presence and absence of specific proteins. Proteins that promote cells to enter and complete cell division belong to a family of proteins known as cyclins. When cyclins are activated, they first allow a cell to leave the G0 state and enter the cycle. These activated cyclins then permit the cell to move through the different phases of the cell cycle and actually divide. The cyclins are the products of oncogenes. See discussion of oncogenes activation on page 407. Proteins produced by suppressor genes regulate the amount of cyclins present in a cell and ensure that cell division occurs only when it is needed. Thus, normal cell division represents a balance between the proteins that promote cell division, cyclins, and the proteins that limit cell division, the suppressor gene products. Figure 23.4 shows the activities of the phases of the cell cycle described below. G1. In this phase, the cell is getting ready for division by taking on extra nutrients, making more energy, and growing extra membrane. The amount of cell fluid cytoplasm also increases. S period, or S dot, S point, S period. Because making one cell into two cells requires twice as much of everything, including DNA, the cell must double its DNA content through DNA synthesis. This process occurs in S phase. Or just maybe it's just S phase. I don't know. G2. Yeah, it's just S phase. G2. In this phase, the cell makes important proteins that will be used in actual cell division and in normal physiologic function after cell division is complete. M phase. The single cell splits apart into two cells, actual mitosis, during M phase. Contact inhibition is the stopping of further rounds of cell division when the dividing cell is completely surrounded and touched or contacted by other cells. Of the normal cells that can divide, each cell divides only when some of its surface is not in direct contact with another cell. Once a normal cell is in direct contact on all surface areas with other cells, it no longer undergoes mitosis. Thus, normal cell division is contact inhibited. Normal chromosomes, or euploidy, is a feature of most normal human cells. These cells have 23 pairs of chromosomes, the correct number for human beings. Each normal mature cell has a specific structure and function. The fact that normal mature cells have many different shapes and functions is interesting considering that all humans started life as a single cell. The function and behavior of that first single cell and its daughter cells are quite different from those of normal adult human cells. Knowledge about these differences has helped in understanding how cancer develops. Features of early embryonic cells. Rapid and continuous cell division is a normal feature of embryonic cells. These cells spend most of their time within the cell cycle actively reproducing. The time it takes one embryonic cell to divide into two cells, generation time, ranges from 2 to 8 hours. These cells also do not respond to signals for apoptosis. Early embryonic cells have long telomeres that do not shorten with each cell division. Although some cells during fetal life undergo apoptosis for development of specific structures, e.g. fingers, this is not a feature of embryonic cells. Anaplasia means without specific shape or differentiation. Early embryonic cells do not look like the mature cells they will eventually become. They all have the same anaplastic appearance, small and rounded. A large nuclear cytoplasmic ratio is a feature of early embryonic cells. The nucleus of these cells is large, taking up most of the space inside the cell. The ratio of the nuclear space to cytoplastic space is larger than that for a normal mature cell. Specific functions are not yet performed by early embryonic cells. They have not yet committed to a specific cell type. Each early embryonic cell is totally flexible and can mature to become any body cell. This flexibility is called pluripotency because each cell has an unlimited potential for maturation. Loose adherence occurs in early embryonic cells because they do not make fibronectin and are not tightly bound together. Migration occurs in each embryonic cell because they are not tightly bound together and can move throughout the early embryo. Contact inhibition does not occur in early embryonic cells, even when all sides of these cells are in continuous contact with the surfaces of other cells. Normal chromosomes are found in early human embryonic cells. These cells have 23 pairs of chromosomes, just like normal, mature human cells have. At about day 8, early embryonic cells start changing into differentiated cells, an event called commitment. In response to unknown signals, each cell commits itself to a specific outcome. The cell has not yet taken on any differentiated features. Rather, it positions itself within a group of cells that will eventually become only one specific organ or tissue. Commitment involves turning off specific early embryonic genes that controlled or regulated early rapid growth. These genes, called oncogenes, remain as normal cellular genes but have limited function after early embryonic life. These genes are usually either turned off, suppressed with little expression, or expressed but tightly controlled. After the early embryonic genes are turned off or suppressed, other specific genes that control the expression of differentiated functions must be turned on or expressed selectively in different cell types. For example, the gene for insulin is actively expressed selectively in different cell types. For example, the gene for insulin is actively expressed only in pancreatic beta cells and is suppressed in all other cells. The selective gene expression directs the normal growth and differentiation of specific body cells. Biology of abnormal cells. Body cells are exposed to personal and environmental conditions that can alter how the cells grow or function. When either cell or cell function is changed, the cells are considered abnormal. Table 23.1 compares features of normal, embryonic, benign tumor, and cancer cells. Features of benign tumor cells. Benign tumor cells are normal cells growing in the wrong place or at the wrong time. Examples include moles, uterine fibroid tumors, skin tags, endometriosis, and nasal polyps. Benign tumor cells characteristics include continuous or inappropriate cell growth occurs in benign tumors. They are tissues not needed for normal function, growing too much or in the wrong place. Specific morphology occurs with benign tumors. They look like the tissues they come from, retaining the specific morphology of parent cells. A small nuclear to cytoplasmic ratio is a feature of benign tumors, just like completely normal cells. Specific differential functions continue to be performed by benign tumors. For example, in endometriosis, one type of benign tumor, the normal lining of the uterus, endometrium, grows in an abnormal place, e.g. on an ovary or on the peritoneum or in the chest cavity. This displaced endometrium acts just like normal endometrium by changing each month under the influence of estrogen. When the hormone level drops and the normal endometrium sheds from the uterus, the displaced endometrium, wherever it is, also sheds. Tight adherence of benign tumor cells to each other occurs because they continue to make fibronectin. In addition, many benign tissues are encapsulated or surrounded with fibrous connective tissue, helping to hold the benign tissue together. No migration or wandering of benign tissues occurs because they remain tightly bound and do not invade other body tissues. Orderly growth with normal growth patterns occurs in benign tumor cells, even though their growth is not needed. Growth may continue beyond an appropriate time, but the rate of growth is normal. The benign tumor grows by hyperplastic expansion and does not invade. Normal chromosomes are usually found in benign tumor cells, although there are exceptions. Most of these cells have 23 pairs of chromosomes, the correct number for humans. Table 23.1 Characteristics of normal and abnormal cells. Characteristic: cell division. Normal cell, none or slow. Embryonic cell, rapid, continuous. Benign tumor cell, continuous or inappropriate. Malignant cell, rapid or continuous. Characteristic: appearance. For a normal cell would be specific morphologic features. Embryonic cell would be anaplastic. Benign tumor cell would be specific morphologic features. And malignant cell would be anaplastic. Characteristic for nuclear cytoplastic ratio would be normal cell would be small, embryonic cell would be large, benign tumor would be small, and malignant cell would be large. Characteristic for differentiated functions: normal cell would be many, embryonic cell would be none, Benign tumor would be many, and malignant cell would be some or none. Characteristic of adherence for normal cell would be tight. Embryonic cell would be loose. Benign cells tight, and malignant cells loose. Migratory characteristic would for normal cell would be no migratory. Embryonic, yes. Benign, no. And malignant, yes. Seeing a pattern here? Yes. Growth for characteristic normal cell would be well regulated. Embryonic cell also well regulated. Benign would be expansion, and malignant would be invasion. And then chromosomes characteristic, normal cell diploid or euploid. Embryonic diploid, euploid. Benign diploid, euploid, and malignant aneuploid. And characteristic mitotic index for normal it would be low, embryonic high, benign low, and malignant high. So, features of cancer cells. Cancer or malignant cells are abnormal, serve no useful function, and are harmful to normal body tissues. Cancers commonly have these features. Rapid or continuous cell division occurs in many types of cancer cells because they re-enter the cell cycle for mitosis almost continuously. In addition, some cancer cells have a short generation time, 2 to 4 hours, but most cancer cells have a generation time similar to that of the parent cells. These cells also do not respond to signals for apoptosis. Most cancer cells have long telomeres and a lot of the enzyme telomerase, which maintains telemetric DNA. As a result, cancer cells do not respond to apoptic signals and have an unlimited lifespan, are immortal. Anaplasia is a feature of cancer cells. They lose the specific appearance of their parent cells. As a cancer cell becomes even more malignant, it becomes smaller and rounded. This appearance change can make diagnosis of cancer type difficult because many types of cancer cells look alike. A large nuclear cytoplasmic ratio is a feature of cancer cells. The nucleus of a cancer cell is larger than that of the normal cell, and the cancer cell is small. The nucleus occupies much of the space within the cancer cell, creating a large nuclear to cytoplasmic ratio. Specific functions are lost partially or completely in cancer cells. Cancer cells serve no useful purpose. Loose adherence is typical for cancer cells because they do not make fibronectin. As a result, cancer cells easily break off from the main tumor. Little bastards, I hate cancer cells. Migration occurs because cancer cells do not bind tightly together and have many enzymes on their cell surfaces. These features allow the cells to slip through the blood vessels and tissues, spreading from the main tumor site to many other body sites. This ability to spread or metastasize is a key feature of cancer cells and a major cause of death. Cancer cells expand and invade other tissues, both close by and more remote from the original tumor. Invasion and persistent growth make untreated cancer deadly. God, I hate cancer. Alright, metastatic spread of breast cancer. Contact inhibition does not occur in cancer cells. Even when all sides of these cells are in continuous contact with the surface of other cells, the persistence of cancer cell division is one factor making the disease so difficult to control. Abnormal chromosomes, or aneuploidy. Abnormal chromosomes are common in cancer cells as they become more malignant. Chromosomes are lost, gained, or broken. Thus, cancer cells can have more than 23 pairs or fewer than 23 pairs. In addition, cancer cells may have broken and rearranged chromosomes. Cancer development, carcinogenesis, and oncogenesis. Carcinogenesis and oncogenesis are other names for cancer development. Table 23.2 lists key concepts about cancer development. The process of changing a normal cell into a cancer cell is called malignant transformation. This process occurs through the steps of initiation, promotion, progression, and metastasis. Initiation is the first step in carcinogenesis. Normally, cells can become cancer cells if they if their oncogenes are turned on excessively or overexpressed at any time after early embryonic life. Anything that can penetrate a cell, get into the nucleus, and damage the DNA can change or mutate the genes. Such changes can activate genes that should remain controlled or suppressed and can turn off normal genes. This type of gene change is known as initiation. Initiation is an irreversible event that can lead to cancer development. After initiation, a cell can become a cancer cell if the cellular changes that occurred during initiation continue and cell division is not impaired. A cancer cell is not a health threat unless it can divide. If it cannot divide, it cannot form a tumor. If growth conditions are right, however, widespread metastatic disease can develop from just one cancer cell. Table 23.2 Key concepts related to cancer development. Neoplastic cells originate from normal body cells. Transformation of a normal cell into a cancer cell involves mutation of the gene's DNA of the normal cell. Early embryonic genes that are overexpressed can cause a cell to develop into a tumor. Excuse me. Only one cell has to undergo malignant transformation for cancer to begin. Benign tumors grow by expansion, whereas malignant tumors grow by invasion. Most tumors arise from cells that are capable of cell division. A key feature of cancer cells is the loss of apoptosis. These cells have an infinite lifespan. Primary prevention of cancer involves avoiding exposure to known causes of cancer. Secondary prevention of cancer involves screening for early detection. Tobacco use is a causative or permissive factor in 30% of all cancers. Damn. Tumors that metastasize from the primary site into another organ are still designated as tumors of the originating tissue. Substances that change the activity of back to this text. Substances that change the activity of a cell's genes so that the cell becomes a cancer cell are carcinogens. Carcinogens may be chemicals, physical agents, or viruses. Table 23.3 lists known chemical and physical carcinogens. Chapters presenting the care of patients with specific cancers discuss specific carcinogens when known within the etiology sections. Promotion is the enhancement of growth of an initial cell. Promoters are substances that promote or enhance growth of an initiated cancer cell. Once a normal cell has been initiated by a carcinogen and is a cancer cell, it can become a tumor if its growth is enhanced. Many normal hormones and body proteins, like insulin and estrogen, can act as promoters and make altered cells divide more frequently. The time between a cell's initiation and the development of an overt tumor is called the latency period, which can range from months to years. Exposure to promoters can shorten the latency period. Progression is the continued change of a cancer, making it more malignant over time. Many processes within the tumor must take place for progression to occur. After cancer cells have grown to the point that a detectable tumor is formed, a 1 centimeter tumor has at least 1 billion cells in it. Other events must occur for this tumor to become a health problem. First, the tumor must develop its own blood supply. In the early stages, the tumor receives nutrition only by diffusion. After the tumor reaches 1 centimeter, however, diffusion is not efficient, and the cells in the center of the tumor become hypoxic and start to die. Let's just die then. To continue to grow and survive, the tumor makes tumor angiogenesis factor, or TAF. TAF triggers capillaries and other blood vessels in the area to grow new branches into the tumor. These blood vessels ensure the tumor's continued nourishment and growth. Good! So this whole chapter just pisses me off. Okay, table 23.3. Known chemical and physical carcinogens. Aflatoxins, whatever those are. Alcoholic beverages. Aminobiphenyls. Arsenic. Asbestos. Azathioprine. Benzene. Benzidine. Beryllium. Cadmium. Chlorambucil, chromium, coal tar, coke oven emissions, cytophosphamide, cyclosporin A, dithystilbestrol, dioxin, drug mixtures containing phenacetin, dyes containing benzidine, areonite, estrogens, ether, ethylene oxide, methylene, mineral oils, myelin, naphthylamine, nickel, nitrogen mustard, nitrosoureas, PUVA, all capitalized, PUVA. Radiation, all types, silica, soot, sulfuric acid, tamoxifen, thiotepa, tobacco smoke and other forms, vinyl chloride, and wood dust. As tumor cells continue to divide, some of the new cells change features from the original initiated cancer cell. Actual colonies or subpopulations within the tumor begin to appear. These cell groups differ from the original cancer cell. Some of the differences provide these cell groups with advantages that allow them to live and divide no matter how the conditions around them change. These differences are thus called selection advantages. Changes that a tumor undergoes at this time can allow it to become more malignant. Over time, the tumor cells have fewer and fewer normal cell features. The original tumor is called the primary tumor. It is usually identified by the tissue from which it arose, or the parent tissue, such as in breast cancer or lung cancer. When primary tumors are located in vital organs, such as the brain or the lungs, they can grow excessively and either lethally damage the vital organ or crowd out healthy organ tissue and interfere with the organ's ability to perform its vital function. At other times, the primary tumor is located in soft tissue that can expand without damage as the tumor grows. One such site is the breast. The breast is not a vital organ, and even if it had a large tumor in it, the primary tumor alone would not cause the patient's death. When the tumor spreads from the original site into the vital areas, life functions can be disrupted and death may follow. Metastasis occurs when cancer cells move from the primary location by breaking off from the original group and establishing remote colonies. These additional tumors are called metastatic or secondary tumors. Even though the tumor is now in another organ, it is still a cancer from the original altered tissue. For example, when breast cancer spreads to the lung and the bone, it is still breast cancer in the lung and bone, not lung cancer and not bone cancer. Metastasis occurs through many steps, as shown in Figure 23.6. You've got malignant transformation. Subnormal cuboidal cells have undergone malignant transformation and have divided enough times to form a tumorous area within the cuboidal epithelium. You've got tumor vascularization. Cancer cells secrete tumor angiogenesis factor TAF, stimulating the blood vessels to bud and form new channels that grow into the tumor. Blood vessel penetration. That would be cancer cells have broken off from the main tumor. Enzymes on the surface of the tumor cells make holes in the blood vessels, allowing cancer cells to enter the blood vessels and travel around the body. Arrest and invasion. Cancer cells clump up in blood vessel walls and invade new tissue areas. If the new tissue areas have the right conditions to support continued growth of cancer cells, and new tumors, metastatic tumors, will form at this site. So tumors first extend into surrounded tissues. The cancer cells secrete enzymes that open up areas of surrounding tissue. Pressure created as the tumor increases in size forces tumor cells to invade new territory. Spread to distant organs and tissues requires cancer cells to penetrate blood vessels. Bloodborne metastasis, tumor cell release into the blood, is the most common cause of cancer spread. Enzymes also make large pores in the patient's blood vessels, allowing tumor cells to enter the blood and circulate through the blood. Because tumor cells are loosely held together, clumps of cell break off of the primary tumor into the blood vessels for transport. Table 23.4, common sites of metastasis for different cancer types. Breast cancer can go into bone, lung, liver, brain, most commonly. Lung cancer are brain, bone, liver, lymph nodes, and pancreas. Colorectal cancer goes to liver, lymph nodes, adjacent structures. Prostate cancer would be bone, especially spine and legs, and pelvic nodes. Melanoma would be GI tract, lymph nodes, lung, brain, and primary brain cancer can go into the central nervous system. Tumor cells circulate through the blood and enter tissues at remote sites. Clumps of cancer cells can become trapped in capillaries. These clumps damage the capillary wall and allow cancer cells to leave the capillary and enter the surrounding tissue. When conditions in the remote site can support tumor cell growth, the cells stop circulating or arrest and invade the surrounding tissue, creating secondary tumors. Table 23.4 lists the common sites of metastasis for specific tumor types. Another way cancers metastasize is by lymphatic spread. Lymphatic spread is related to the number, structure, and location of lymph nodes and vessels. Primary sites that are rich in lymphatics have more early metastatic spread than areas with few lymphatics. Cancer classification. Cancers are classified by the type of tissue from which they arise, e.g. glandular or connective. Terms that describe cancer by tissue origin are listed in Table 23.5. Other ways to classify cancer include biologic behavior, anatomic site, and degree of differentiation. About 100 differtypes stupid word, differtypes of cancer arise from various tissues or organs. Figure 23.7 compares cancer distribution by site. Figure 23.7, cancer incidence by death, by site, and gender. And it says, rights were not granted to include this data in electronic media. Please refer to the printed book. Okay, so I guess you're going to have to refer to the book for cancer incidence and death by site and gender, figure 23.7. So, about 100 differtypes of cancer arise from various tissues or organs. Figure 23.7 compares cancer distribution by site and gender. Cancers are divided into two major categories, solid and hematologic. Okay, well, how about Table 23.5, classifications of tumors by tissue of origin. Prefix, adeno, tissue of origin would be epithelial glands. Benign tumor would be an adenoma, and a malignant tumor would be an adenocarcinoma. Then there's the prefix would be chondro. Tissue of origin would be the cartilage. Benign tumor would be a chondroma, and a malignant tumor would be a chondrosarcoma. Chondrosarcoma. Prefix fibro. Tissue of origin, fibrous connective tissue. And a benign tumor would be a fibroma, and a malignant tumor would be a fibrosarcoma. Then there's glio. That would be the glial cells in the brain, and a benign tumor would be a glioma, and a malignant tumor would be a glioblastoma. Then there's hemanagio, and that would be a blood vessel. Benign tumor would be a hemanagio. Hemangioma, and then a malignant tumor would be a hemangiosarcoma. Prefix hepato would be liver, hepatoma, or malignant would be a hepatocarcinoma. And then there's a hepatoblastoma for malignant. Leiomyo, that would be smooth muscle. Benign tumor would be a leiomyoma. Malignant tumor would be a leiomyosarcoma. Lipo would be fat or adipose tissue. Be a lipoma for benign, and a liposarcoma for malignant. Lymphoid tissue. There's no benign, but for malignant it would be a malignant lymphomas, Hodgkin's lymphoma, non-Hodgkin's lymphoma, Burkitt's lymphoma, cutaneous T cell. Then there's melano, the pigment producing skin, nothing for benign, and then melanoma for malignant. Meningioma, that would be the meninges, and that would be a meningioma for benign, and a malignant meningioma, and also a meningioblastoma. Then there's neuro, would be nerve tissue, be a neuroma or a neurofibroma for benign, and then a neurosarcoma or a neuroblastoma for malignant. There's osteo, that's bone, osteoma or for benign, and then malignant would be osteosarcoma or renal cell. Oh wait, nope, just osteosarcoma. Sorry. Then there's renal, which would be kidney, nothing for benign. Malignant would be renal cell carcinoma. Then rhabdo, which would be skeletal muscle, and that would be rhabdomyoma for benign, and a rhabdomyosarcoma for malignant. Squamous would be epithelial layer of skin, mucous membrane, and organ linings. It would be papilloma for benign, and squamous cell carcinoma of skin, bladder, lungs, and cervix. Solid tumors develop from specific tissues, e.g. breast cancer, lung cancer. Hematologic cancers arise from blood cell forming tissues, e.g. leukemias, lymphomas. Cancer grading, ploidy, and staging. Systems of grading and staging have been developed to help standardize cancer diagnosis, prognosis, and treatment. Grading of a tumor classifies cellular aspects of the cancer. Ploidy classifies tumor chromosomes as normal or abnormal, and staging classifies clinical aspects of the cancer. Grading is needed because some cancer cells are more malignant than others, varying in their aggressiveness and sensitivity to treatment. Some cancer cells barely resemble the tissue from which they arose, are aggressive, and spread rapidly. These cells are high-grade cancer. On the basis of cell appearance and activity, grading compares the cancer cell with the normal parent tissue from which it arose. Different clinical groups have established different grading systems for different types of cancer cells, but overall they resemble the standard system listed in Table 23.6. This system rates cancer cells with the lowest rating given to those cells that closely resemble normal cells, and the highest rating given to cancer cells that barely resemble normal cells. Grading the cells is one of the first steps in confirming cancer. Grading is a means of evaluating the patient with cancer for prognosis and appropriate therapy. It also allows health care professionals to evaluate the results of management and compare local, regional, national, and international statistics. Table 23.6, Grading of Malignant Tumors. Grade cellular characteristics. GX, grade cannot be determined. G1, tumor cells are well differentiated and closely resemble the normal cells from which they arose. This grade is considered a low grade of malignant change. These tumors are malignant but are relatively slow growing. G2, tumor cells are moderately differentiated. They still retain some of the characteristics of normal cells, but also have more malignant characteristics than do G1 tumor cells. G3, tumor cells are poorly differentiated, but the tissue of origin can usually be established. The cells have few normal cell characteristics. G4, tumor cells are poorly differentiated and retain no normal cell characteristics. Determination of the cell of origin is difficult and perhaps impossible. Ploidy, Ploidy, is the description of cancer cells by chromosome number and appearance. Normal human cells have 46 chromosomes, or 23 pairs. The normal diploid number, or euploidy, When malignant transformation occurs, changes in the genes and chromosomes also occur. Some cancer cells gain or lose whole chromosomes and may have structural abnormalities of the remaining chromosomes. Aneuploidy, or called aneuploidy. The degree of aneuploidy usually increases with the degree of malignancy. Some specific chromosome changes are associated with specific cancers, and their presence is used for diagnosis and prognosis. For example, one example is the Philadelphia chromosome abnormality, often present in chronic myelogenous leukemia cells. See Chapter 42. Table 23.7, Staging of Cancer, TNM classification. Primary tumor, T. TX. Primary tumor cannot be assessed. T0. No evidence of primary tumor. T is IS. Carcinoma in situ. T1, T2, T3, and T4. Increasing size and or local extent of the primary tumor. Regional lymph nodes, N. NX. Regional lymph nodes cannot be assessed. And 0, no regional lymph node metastasis. And 1, 2, and 3, increasing involvement of regional lymph nodes. Then distant metastasis, or M. MX. Presence of distant metastasis cannot be assessed. M0, no distant metastasis. M1, distant metastasis. So then there's staging. Staging determines the exact location of the cancer and its degree of metastasis at diagnosis. Staging is important because for most cancers, the smaller the cancer is at diagnosis and the less it has spread, the greater the chances that treatment will result in a cure. Cancer stage also influences selection of therapy. Staging is done by clinical staging, surgical staging, and pathologic staging. Clinical staging assesses the patient's clinical manifestations and evaluates clinical signs for tumor size and possible spread. Surgical staging assesses the tumor size, number, sites, and spread by inspection at surgery. Pathologic staging is the most definitive type, determining the tumor size, number, sites, and spread by pathologic examination of tissues obtained at surgery. Specific staging systems include Duke's staging of colon and rectal cancer and Clark's levels method of staging skin cancer. The American Joint Committee on Cancer Development on Cancer developed the tumor node metastasis, or TNM, system to describe the anatomic extent of cancers. The stages guide treatment and are useful for prognosis and comparison of treatment results. The TNM staging systems have specific prognostic value for each solid tumor type. Table 23.7, which we just read, shows a basic TNM staging system. The TNM staging is not useful for leukemia or lymphomas. Staging for these cancers is discussed in Chapter 42. Tumor growth is assessed in terms of doubling time, the amount of time it takes for a tumor to double in size, and mitotic index, the percentage of actively dividing cells within a tumor. The smallest detectable tumor is about 1 centimeter in diameter and contains 1 billion cells. To reach this size, it must undergo at least 30 doublings. A tumor with a mitotic index of less than 10% is a slow-growing tumor. A tumor with an index of 85% is fast-growing. The tumors have a wide range of growth rates. Fast-growing tumors, such as lymphomas, may double in 4 weeks, and adrenocarcinomas of the lung may double in 20 to 40 weeks. Cancer etiology and genetic risk. Carcinogenesis takes years and depends on several tumor and patient factors. 3 interacting factors influence cancer development: exposure to carcinogens, genetic predisposition, and immune function. These factors account for variation in cancer development from one person to another, even when each person is exposed to the same hazards. Oncogene activation is the main mechanism of carcinogenesis, regardless of their specific cause. These oncogenes were the genes that directed early embryonic development at about 8 days after conception. These genes should be controlled forever. They are turned on under controlled conditions when cells need to divide for normal growth and replacement of dead or damaged tissues. At other times, they are turned off, controlled, or suppressed by suppressor genes. Suppressor genes can act directly at the DNA level, preventing the oncogene from being overexpressed. Another way that suppressor genes work is by preventing cells from dividing or maintaining control over the cell. When a normal cell is exposed to any carcinogen or initiator, this normal cell's DNA can be damaged or mutated. The mutations damage suppressor genes, preventing them from controlling the expression of oncogenes. As a result, the oncogenes are overexpressed and can cause the cells to change from normal cells to cancer cells. When oncogenes are overexpressed in a cell, excessive amounts of cyclins are produced and upset the balance between cell growth and enhancement and cell growth limitation. The effect of these excessive cyclins is greater than the effect of the suppressor gene products, thus allowing uncontrolled cell division. About 70 different oncogenes have been identified. These oncogenes are not abnormal genes, but are part of every cell's normal makeup and were important in early development. Oncogenes become a problem only if they are activated and overexpressed as a result of exposure to carcinogenic agents or events. Both external and personal factors can activate oncogenes. External factors causing cancer. External factors, including environmental exposure, are responsible for about 80% of cancer in North America. Environmental carcinogens are chemical, physical, or viral agents that cause cancer. The National Toxicology Program has identified 58 agents known to cause cancer in humans and another 188 agents suspected to be carcinogens. Table 23.3 lists some known chemical and physical causes of human cancer. Chemical carcinogenesis can occur from exposures to many known chemicals, drugs, and other products used in everyday life. Hundreds more are suspected of being carcinogenic. Chemicals vary in how carcinogenic they are. Some substances, such as tobacco and alcohol, appear to be only mildly carcinogenic. It takes long-term exposure to large amounts of these substances before a cancer develops. However, these two substances can act as co-carcinogens. When taken together, they enhance each other's carcinogenic activity. Not all cells are susceptible to chemical carcinogenesis to the same degree. Normal cells that have ability to divide are at greater risk for cancer development than are normal cells that are not capable of cell division. For example, cancers commonly arise in bone marrow, skin, lining of the GI tract, ductal cells of the breasts, and lining of the lungs. All of these cells normally undergo cell division. Cancers of nerve tissue, cardiac muscle, and skeletal muscle are rare. These cells do not normally undergo cell division. About 30% of cancers diagnosed in North America are related to tobacco use. Tobacco is the single most important source of preventable carcinogenesis. It contains many different carcinogens and co-carcinogens. Tobacco use both initiates and promotes cancer. The risk for cancer development from tobacco use depends on a person's immune function, amount of tobacco exposure, type of tobacco exposure, and tobacco tar content. Tissues with the greatest risk for tobacco-induced cancer are those that have direct contact with tobacco or tobacco smoke. Cigarette smoking and tobacco use also promotes the development of other cancers. Table 23.8 lists the specific cancers that appear to be associated with tobacco use. Physical carcinogenesis from physical agents or events causes cancer by the same mechanism as for chemical carcinogens, i.e. DNA damage. Two physical agents that are known to cause cancer are radiation and chronic irritation. Even small doses of radiation affect cells. Some effects are temporary and can be repaired. Other effects cannot be repaired and either may be lethal to the damaged cell or induce cancer in the damaged cell. The two types of radiation that cause cancer are ionizing and ultraviolet, or UV. Some ionizing radiation is found naturally in such elements as radon, uranium, and radium. Most rocks and soil contain various amounts of uranium and radium. Other sources of ionizing radiation include X-rays for diagnosis and treatment of disease, as well as cosmic radiation. UV radiation is a type of solar radiation coming from the sun. Other sources of UV radiation include tanning beds and germicidal lights. UV rays do not penetrate deeply, and the most common cancer type caused by UV exposure is skin cancer. Both ionizing and UV radiation mutate genes. Although radiation exposure induces cancer more often among cells that can divide, it can cause cancer among non-dividing cells as well. Chronic irritation and tissue trauma are suspected to cause cancer. The incidence of skin cancer is higher in the scars of people with burn scars or other types of severe skin injury. Chronically irritated tissues undergo frequent cell division and thus are at an increased risk for spontaneous DNA mutation. Viral carcinogenesis occurs when viruses infect body cells and break the DNA strands. Viruses then insert their own genetic material into the human DNA. Breaking the DNA along with viral gene insertion mutates the normal cell's DNA and can either activate an oncogene or damage suppressor genes. Viruses that cause cancer are oncoviruses. Table 23.9 lists cancers of known viral origin. Table 23.8, cancer types associated with tobacco use: lung, oral cavity, pharyngeal, laryngeal, esophagus, pancreatic, cervical, kidney, bladder, liver, stomach, and myeloid leukemia. Dietary factors related to cancer development are poorly understood, although dietary practices are suspected to alter cancer risks. Because dietary factors are rarely independent of other possible carcinogenic agents, evidence of dietary contributions to cancer development is clouded. Suspected dietary factors include low fiber intake, high intake of red meat, and high animal fat intake. Preservatives, contaminants, preparation methods, and additives, dyes, flavorings, sweeteners may have cancer-promoting effects. Chart 23.1 lists foods that have carcinogenic potential and those that are thought to be protective against cancer development. Personal factors and cancer development. Personal factors including immune function, age, and genetic risk also affect whether a person is likely to develop cancer. Immune function protects the body from foreign invaders and non-self cells. See Chapter 19. Non-self cells include cells that are no longer normal, such as cancer cells. The part of the immune system that protects against cancer is cell-mediated immunity, or natural killer NK and helper T cells provide immune surveillance. Table 23.9, cancers associated with known viral origin. Epstein-Barr virus. Okay, the virus would be the Epstein-Barr virus, and malignancies associated would be Burkitt's lymphoma, B-cell lymphoma, and nasopharyngeal carcinoma. The virus, hepatitis B virus, malignancy would be primary liver carcinoma. Hepatitis C virus, primary liver carcinoma, possibly B-cell lymphomas. Human papilloma virus is associated with cervical carcinoma, vulvar carcinoma, and other anogenital carcinomas. Human lymphotrophic virus type 1 would be adult T-cell leukemia, and human lymphotropic virus type 2 would be hairy cell leukemia. Chart 23.1, Patient and Family Education Guide, Dietary, Habits to Reduce Cancer Risk. Avoid excessive intake of animal fat. Avoid nitrates, prepared lunch meats, sausage, bacon, any processed food. Okay, avoid nitrates. Minimize your intake of red meat. Keep your alcohol consumption to no more than 1 or 2 drinks per day. Eat more bran. Eat more cruciferous vegetables such as broccoli, cauliflower, Brussels sprouts, and cabbage. Eat foods high in vitamin A, e.g. apricots, carrots, leafy greens, and yellow vegetables. And vitamin C, e.g. fresh vegetables, fruits, and especially citrus fruits. Let's see, back to the text, the role of the immune system in protecting against cancer is supported by cancer incidence in immunosuppressed people. Older adults older than 60 years old have immune systems that function at less than optimal levels, and therefore this group has a higher incidence of cancer compared with that of the general population. Organ transplant recipients take immunosuppressive drugs to prevent organ rejection, also have a higher incidence of cancer. In patients with acquired immune deficiency syndrome, AIDS, incidence may be as high as 70%. Table 2310, the 7 warning signs of cancer. And the acronym is CAUTION. So C, changes in bowel or bladder habits. A sore that does not heal. U, unusual bleeding or discharge. T, thickening or lump in the breast or elsewhere. I, indigestion or difficulty swallowing. O, obvious change in a wart or mole. N, nagging cough or hoarseness. Advancing age is the single most important risk for cancer. As a person ages, immune protection decreases and external exposures to carcinogens accumulate. Manifestations of cancer in older patients may be overlooked as changes of normal aging. Teach older adults to be aware of and report symptoms such as the 7 warning signs of cancer to healthcare providers. Healthcare providers should investigate all manifestations suggestive of disease. Cancer assessment considerations for the older adult are listed in Chart 23.2. Chart 23.2. Nursing focus on the older adult. Hematologic assessment. Cancer type assessment consideration. Colorectal cancer. Ask the patient whether bowel habits have changed over the past year, e.g. in consistency, frequency, or color. Is there any obvious blood in the stool? Test at least 1 stool specimen for occult blood during the patient's hospitalization. Encourage the patient to have a baseline colonoscopy. Encourage the patient to reduce dietary intake of animal fats, red meat, and smoked meats. Encourage the patient to increase dietary intake of bran, vegetables, and fruit. Bladder cancer. Ask the patient about the presence of pain on urination, blood in the urine, cloudy urine, increased frequency or urgency. Prostate cancer. Ask the patient about hesitancy, change in the size of the urine stream, pain in the back or legs, history of urinary tract infections. Skin cancer. Examine skin areas for moles or warts. Ask the patient about changes in moles, e.g. color, edges, and sensation. Leukemia. Observe the skin for color, petechiae, or ecchymosis. Ask the patient about fatigue, bruising, bleeding tendency, history of infections and illnesses, night sweats, unexplained fevers. Lung cancer. Observe the skin and mucous membrane for color. How many words can the patient say between breaths? Ask the patient about cough, hoarseness, smoking history, exposure to inhalation irritants, shortness of breath, activity tolerance, frothy or bloody sputum, pain in the arms or chest, difficulty swallowing. Genetic considerations. Genetic risk for cancer occurs in a small percent of the population. However, people who have a genetic predisposition are at very high risk for cancer development. As previously discussed, oncogenes are risk factors related to carcinogenesis. Altered oncogenes are passed on from generation to generation. The development of cancer, however, depends on more than these genes. The oncogene must be overexpressed for cancer to occur. In some people, the sequence of a specific oncogene is different or has been mutated. which may allow it to be activated more easily. In other people, the oncogene is normal, but the gene controlling oncogene activity, the suppressor gene, is mutated and allows overexpression of one or more oncogenes, leading to a huge increase in cancer risk. These variations in gene sequence may be small single nucleotide polymorphisms, or SNPs, or may be large areas of mutation. Both types of gene problems can be inherited or can occur as a result of exposure to carcinogens. Patterns of genetic risk for cancer have also been identified, including inherited predisposition for specific cancers, inherited conditions associated with cancer, familial clustering, and chromosomal aberrations. Genetic testing for cancer predisposition is available to confirm or rule out a person's genetic risk for a specific cancer. These tests are performed on blood, are expensive, and often are not covered by insurance. Genetic testing should not be performed unless a family history clearly indicates the possibility of increased genetic risk and the patient wants to have the test results. These tests do not diagnose the presence of cancer. A variety of issues and potential problems exist with genetic testing for cancer risk. Correct interpretation of the results is critical. Ideally, a genetic counselor is involved in giving the patient information before as well as after testing is performed. A patient's positive test result for a cancer-causing gene mutation shows that he or she is at greatly increased risk for cancer development. However, the cancer still may be developed, may never be developed. Table 2311. Conditions associated with a genetic predisposition for cancer. Inherited cancers. Specific cancer type would be breast cancer, prostate cancer, ovarian cancer. Familial clustering would be breast cancer, melanoma. Bloom syndrome. Bloom syndrome has to do with leukemia. Familial polyposis has to do with colorectal cancer. Chromosomal aberrations like Down syndrome, which is 47 chromosomes, has to do with is linked with leukemia. Klinefelter syndrome, 47, and an XXY has to do with breast cancer, associated with breast cancer. Turner syndrome, 45 chromosomes, is associated with leukemia, gonadal carcinoma, meningioma, and colorectal cancer. But not all breast, prostate, or ovarian cancers are inherited. Other issues regarding genetic testing include who will have access to the information and whether to share the test results with family members. Many patients fear that if they test positive for a cancer-causing gene, they may face discrimination for insurance coverage or in the workplace. Some states have confidentiality safeguards, and others do not. Genetic testing has implications for the entire family, not just the patient being tested. For more information on genetic testing, see Chapter 6. Cultural awareness. The incidence of cancer varies among races. American Cancer Society data 2007 show that African American have a higher incidence of cancer than white people do, and the death rate is higher for African Americans. Since 1960, the overall incidence among African Americans has increased 27%, whereas for white people it has increased 12%. Cancer sites and cancer-related mortality vary along racial lines as well. One explanation for this difference is that more African Americans have less access to health care. Thus, they are more often diagnosed with later stage cancer that is more difficult to cure or control. However, this disparity in health care access does not explain all differences. Table 2312 shows common cancers among white, African American, Asian, and Hispanic populations. Understanding these variations can help in planning, prevention, and early detection strategies that are ethnically specific. When Risks for cancer development are assessed. However, ethnicity and genetic predisposition cannot be considered alone. Behavior and socioeconomic factors must also be assessed. The American Cancer Society reports that cancer incidence and survival are often related to socioeconomic factors. These factors include the availability of healthcare services or the belief that seeking early health care has a positive effect on the outcome of cancer diagnosis. Table 2312, Racial Differences in Cancer Development. White, common cancer types for white people would be lung, breast, colorectal, and prostate. African American, common cancer types would be lung, prostate, breast, colorectal, and uterine. So all the same except uterine. Asian, common cancer types, breast, colorectal, prostate, lung, stomach. Okay, they're all the same except there's always just one different one, and they just put them in different order. Ugh, it's annoying, sorry. So stomach is the different one there. Hispanic, common cancer types, prostate, breast, colorectal, and lung. Wow, that's totally not useful. Okay. Cancer prevention. Cancer prevention activities can focus on primary prevention or secondary prevention. Primary prevention is the use of strategies to prevent the actual occurrence of cancer. This method of cancer prevention is most effective when there is a known cause for a cancer type. Secondary prevention is the use of screening strategies to detect cancer early, at a time when cure or control is more likely. Primary prevention, avoidance of a known or potential carcinogens, is an effective primary prevention strategy. This method is effective when a cause of cancer is known and avoidance is easily accomplished. For example, teach people to use skin protection during sun exposure to avoid skin cancer. Much lung cancer can be avoided by not using tobacco and by eliminating environmental asbestos exposure. Teach everyone about the dangers of cigarette smoking and other forms of tobacco use. Provide information on smoking cessation strategies and support systems. As more cancer causes are identified, avoidance may become even more effective. Modifying associated factors appears to have a positive influence in reducing cancer risk. Absolute causes are not known for many cancers, but some conditions appear to increase risk. Examples are the increased incidence of cancer among people who consume alcohol, the association of a diet high in fat and low in fiber with colon cancer, breast cancer, and ovarian cancer, and greater incidence of cervical cancer among women who have multiple sexual partners. Modifying behavior to reduce the associated factor may decrease the risk for cancer development. Therefore, teach all people to limit their intake of alcohol to no more than 1 ounce per day and to include more fruit, vegetables, and whole grains in their diets. Instruct women about the importance of limiting the number of sexual partners and to use safer sex practices to avoid exposure to viruses that can increase the risk of cervical cancer. Removal of at-risk tissues reduces cancer risk for a person who has a known high risk of developing a specific type of cancer. Examples include removing moles to prevent conversion to skin cancer, removing colon polyps to prevent colon cancer, and removing breasts to prevent breast cancer. Not all at-risk tissue can be removed, e.g. those that are part of essential organs. Chemo prevention is a newer form of potential cancer prevention. This strategy uses drugs, chemicals, natural nutrients, and other substances to disrupt one or more steps important to cancer development. These agents may be able to reverse existing gene damage or halt the progression of the transformation process. Table 2313 lists agents found effective and are commonly prescribed. These include the use of aspirin and celecoxib or Celebrex to reduce the risk for colon cancer. The use of vitamin D and tamoxifen to reduce the risk of breast cancer, and the use of lycopene to reduce the risk of prostate cancer. The goal of chemo preventive strategies is prevention of cancer development. Target populations for whom chemo prevention might be effective include healthy people with no known specific cancer risk, people at greater than normal risk because of increased environmental exposure or decreased immune function, people with precancerous lesions, people with a history of cancer. Vaccination is a new method of primary cancer prevention. Currently, the only vaccine approved for cancer prevention is Gardasil, which prevents infection from several forms of the human papillomavirus, or HPV. As more viruses are identified as being cancer-causing, it is hoped that vaccines will be developed to prevent those viral infections. Table 2313, Agents under investigation for chemo prevention of cancer. Category of prevention. Prevention of carcinogen formation. Special agents would be ascorbic acid or vitamin C, tocopherol or a type of vitamin E, selenium, and caffeic acid. Category prevention, blocking the action of a carcinogen on DNA or anti-mutagens would be carotenoids or vitamin A derivative, retinoids, another vitamin A derivative, ellagic acid, flavones, ultipraz, butylated hydroxynisol, butylated hydroxynisol. Okay, then category would be the next category is enhancing the elimination of a carcinogen, and those would be isothiocyanate and indole 3-carbinol. Next category would be suppression of carcinogenic suppression of carcinogenic action, and those would be aspirin, retinoids, lycopene, indomethacin, selenium, steroidal anti-inflammatory agents, protease inhibitors. And then another category would be anti-promotion activity. You'd have carotenoids, lycopene, retinoids, selenium, coumarin, pyroxicam, indomethacin, calciferol or vitamin D, hormone antagonists, tamoxifen, finasteride, and Avista. And then another category is suppression of progression, and for that you can take danazol, interferon, cysteamine, or vorazol. Okay, now on to secondary prevention. Regular screening for cancer does not reduce cancer incidence, but can greatly reduce some types of cancer deaths. Teach all adults the benefits of participating in specific routine screening techniques annually as part of health maintenance. General screening recommendations are listed in chapters discussing cancers by organ system. The age and type of participation in specific screening tests are different for people who have an identified increased risk for a specific cancer type. Examples of recommended screenings include yearly mammography for women older than 40 years, yearly clinical breast examination for women older than 40 years, colonoscopy at age 50 years and then every 10 years, yearly fecal occult blood for adults of all ages, yearly prostate specific antigen or PSA test, and digital rectal examination DRE for men older than 50 years. Because cancer development clearly involves gene changes, either inherited gene mutations or acquired gene damage, researchers have suggested that altering damaged genes could prevent cancer development. Currently, people can be screened for some gene mutations that increase the risk for cancer. Examples of these gene mutations include the BRCA1 gene, which increases the risk for both breast and ovarian cancer, the BRCA2 gene, which increases the risk for breast cancer, and the APC, MLH1, and MSH2 genes, which increase the risk for colon cancer. When taking a patient history and the person appears to have a strong family history of either breast cancer or colon cancer, create a 3-generation pedigree to more fully explore the possibility of genetic risk. If a pattern of risk emerges, inform the person that the possible benefits of genetic screening and to talk with a genetics professional for more information is probably a good idea. Screening can help a person at increased genetic risk for cancer to alter lifestyle factors, participate in early detection methods, or have at-risk tissue removed. Genetic screening has some personal risks as well as potential benefits. See Chapter 6. Although it is not yet possible to fix or remove an abnormal gene in humans, gene therapy in the future is not out of the realm of possibility. Get ready for NCLEX examination. Key points. Review these key points for each NCLEX examination client need categories. Health promotion and maintenance. Teach patients to use sunscreen and to wear protective clothing during sun exposure. Encourage patients to participate in the recommended cancer screening activities for their age group and cancer risk category. Inform all patients who smoke that smoking increases the risk of development of many cancer types. Assist anyone interested in smoking cessation to find an appropriate smoking cessation program. Assess the patient's knowledge about causes of cancer and his or her screening prevention practices. Assist patients who fear a cancer diagnosis to understand that finding cancer at an early stage increases the chances for a cure. Teach patients who undergo genetic testing for cancer predisposition about the risks to confidentiality of the test results. Ask all patients about their exposures to environmental agents that are known or suspected to increase the risk for cancer. Obtain a detailed family history, at least 3 generations, to assess the patient's risk for familial or inherited cancer. Teach anyone, especially older adults, the 7 warning signs of cancer. Caution. Physiological integrity. Cancer cells originate from normal body cells. Transformation of a normal cell into a cancer cell involves mutation of the genes or DNA of the normal cell. Oncogenes that are overexpressed can cause a cell to develop into a tumor. Only one cell has to undergo malignant transformation for cancer to begin. Benign tumors grow by expansion, whereas malignant tumors grow by invasion. Most tumors arise from cells that are capable of cell division. A key feature of cancer cells is the loss of apoptosis. These cells have an infinite lifespan. Primary prevention of cancer involves avoiding exposure to known causes of cancer. Secondary prevention of cancer involves screening for early detection. Tobacco use is a causative factor in 30% of all malignant neoplasms. Tumors that metastasize from the primary site into another organ are still designated as tumors of the originating tissue. All right, and that was Chapter 23. Iggy.